Yeah, so what we did was we followed up a trial that was done many, many years ago called the United Kingdom Prospective Diabetes Study that was founded in 1977 and randomly allocated people to more or less intensive blood pressure control or more or less or intensive glucose control for a period of up to 10 years. What we were interested in is whether that period of better glucose control or that period of better blood pressure control would reduce the risk of later dementia. And because dementia takes many years to develop, we would need to follow those people up for a long, long time. So that's the results that we were presenting in Munich. Yeah, so the UKPDS study was included about 5,000 people, and those people were randomized into different interventions. So a number of people were randomly allocated to sulfonylurea insulin or standard control back in 1977. People were randomly allocated to tight versus less tight blood pressure control, and people are randomly allocated to metformin or standard blood pressure control. And remembering, of course, that blood pressure control in the 1970s, glucose control in the 1970s is very different to what it is today. So, for example, the blood pressure randomization, those people with tight blood pressure control had about a 10 millimeter of mercury lower systolic blood pressure than those people in the less tight blood pressure control. And there was about a 1% difference in the HbA1c in people allocated sulfonylurea and insulin versus standard control. So the interventions achieved quite a big difference in the size, if you like, of the expected effect on biomarkers. And we then followed those people up for many, many years to find out what people's incidence was of stroke and what people's incidence was of dementia. And to cut a long story short, there was no statistically significant difference in the incidence of stroke or dementia in the treatments. But because there were a relatively small number of people in each of those interventions, didn't exclude an effect, didn't exclude a potentially beneficial effect, and didn't exclude a potentially harmful effect. So as often is the case, more data is needed. There were no surprises here. It would have been nice to have seen a difference one way or the other. And the reason for that is that much of public health recommendations in dementia are to try to intervene on vascular risk factors in midlife to see whether there's any reduction in dementia incidence in late life. We didn't see any of that. So I suppose what that tells us is the effect size isn't very, very large. It's probably modest. And modest doesn't mean not worthwhile, because that's the effect of many treatments is modest. But we can't definitively say how big the effect is or whether that effect is definitely positive or definitely negative.